Hey guys, it's Sharon Hollis here, physical therapist. Today I want to talk about muscle inhibition. What muscle inhibition is, first, it is an involuntary dysfunction, an involuntary normal dysfunction of muscle. Please hear the word involuntary. You don't have control over this. Muscle inhibition is when muscle tissue, not the whole muscle, is muscle tissue, actin and myosin, the protein in muscles, need to shorten and lengthen. For some reason, they can get stuck where they don't lengthen or shorten. Muscle tissue, actin and myosin are proteins. They need a way to communicate to the central nervous system. We have something in our muscle called the muscle spindle. The muscle spindle is what connects the actin and myosin, or the protein in our muscles, to the nervous system. For various reasons, which I won't get in here, that spindle can go slack. When that happens, muscle tissue doesn't shorten or lengthen. It gets stuck. And I have literally had patients tell me, in their own words, I feel stuck. They can't stretch, or when they try to stretch, it doesn't feel like it lengthens. And muscle inhibition, when it goes on long enough, can lead to weakness. Typically, muscle inhibition, I think, starts to cause the aches and pains around late 30s, early 40s. Again, these are just my observations of my theory. Now, muscle inhibition is not a theory. There are hundreds, if not thousands, of peer-reviewed publications on this topic. Most of the publications involve the quadricep because it's very well known after ACL reconstruction that a lot of people don't get their full strength back. Anytime you have knee surgery, knee injury, tweak the knee, and I'll give you an example in a few minutes, there is a reflex inhibition of the quadricep. That happens 100% of the time. I think that's why most of the research is done on the quadricep. But I'm here to tell you now, muscle inhibition is a normal dysfunction of any muscle in the entire body on any person. One example is I had surgery on my shoulder in 1991 to correct an instability. Well, it corrected the problem, but I couldn't sleep on my shoulder for 20 years. And trust me, I tried everything. Massage, strengthening, and what actually happened when I tried to strengthen, everything would start to tighten up from here down to here. So strengthening actually made me worse. Once I learned about muscle inhibition and how muscles fail to work, I got rid of 20 years of pain in 3 days because one of the large muscles in my rotator cuff was not contracting well. And every time I laid down on the arm, I assume it slipped a little bit out of joint or whatever because the subscapularis wasn't holding in place. I activated the subscapularis, meaning I brought the muscle spindle back on board, made them do their job again, boom, pain is gone. So again, muscle inhibition is an involuntary normal dysfunction of muscle. And I'm going to so let me back up. We talked about the quadricep. Well, a couple weeks ago, I was walking in a parking lot, not paying attention, and I kicked my toe in one of those concrete barriers where cars pull up to, and boom, down I went. Elbow, knee, fell right on my knee. So interestingly, about a week later, my legs started giving out. It was that quick, like wanting to give out. Well, I knew immediately what it was. It was muscle inhibition of the quadriceps because I had fallen on my knee. Well, guess what? There is a very effective way to correct muscle inhibition. If muscle inhibition is the inability to contract a muscle from within, okay, you can't contract it because it's not connected to your nervous system. You can do all the exercise you want. If it's not contracting it's not contracting, okay? If that's the case, then you need an external source to create that contraction. Now, sometimes, and you might hear therapists talk about this, isometrics, which is where you lightly tighten a muscle. Well, if you want to try to activate a muscle, it is a very light isometric. Isometric is when you tighten a muscle without movement, okay? So I'm doing an isometric of my bicep. I'm tightening it, right? You can't really see my massive bicep, can you? All right, I'm tightening it, I'm holding it, and you hold it for about 6 seconds, release. Hold, light, tighten, 6 seconds, release. That is a method of trying to restore muscle activation when a muscle is inhibited. In fact, that's how I got my shoulder back to working. I did isometrics. I took a band and I did internal rotation, subscapularis, does internal rotation. I did that in multiple angles, laying down, and I got my muscle firing again. Sometimes isometrics are not enough. So the solution is, the best solution, some people will use electrodes and put that on the skin to help get a muscle to contract. Well, oftentimes the amount of electricity you need to get specifically the quadriceps to contract is more than a person can tolerate. So I have found in my practice, and I do this all the time, I use dry needling with electricity, intramuscular electrical stim. This way, without question, I am getting electricity into the muscle and making it contract. I have many examples of people who've come to see me with, I'll just throw one out there. I had a lady who had a knee replacement. She had gone through traditional therapy. She was still having all sorts of problems with her knee, couldn't walk up and down stairs, was really frustrated. And the therapist was like, well, you know, kind of, that's as good as it gets, right? Well, I knew immediately the problem was quadriceps inhibition. So I needed her a couple times, then we did strengthening and I corrected other imbalances that happened. I don't need to go in all more details about that. And she was 100%. Another example, and this is a much more complex case, had an 80-year-old patient who had had both knees replaced maybe 6 or 7 years prior. When she came to me, her main issue is balance. Well, a lot of therapists would just start balance training, nothing wrong with that. But I was like, wait a minute, you had 2 knee replacements, let me just check the quads. Sure enough, they were atrophied, barely firing. So she had developed the ability to walk with quadriceps that really weren't holding her up. Long story short, we started with activation for the quadriceps with intramuscular electrical stim. And of course, there were a lot of other issues to address, but I don't need to go into detail about that. So muscle inhibition can also be a reason for chronic pain. When muscles become inhibited, they can stay inhibited for a long time, 20 years on me. Muscle inhibition can be a reason for failed surgeries. Here's an example of someone I know. In her mid-60s, that's her age, mid-late 60s, she had a shoulder replacement 6-7 years ago. Well, recently she lost the ability to lift her shoulder. There's nothing wrong with the joint. The metal plate and artificial joint are fine. She can't move because the muscles aren't working. After major surgery, rotator cuff repair, shoulder replacement, guess what? The muscles don't always come back to work. So because the rotator cuff on her shoulder replacement never came back to work, gradually got weaker, can't lift the arm. Oh, now we're going to do a reverse total shoulder. So that's just another example of how muscle inhibition effects rehab, and that is a well documented reason for poor rehabilitation. And again, most of the literature is on knees, but Achilles tendon repair, there's a bunch of literature out there talking about loss of strength years out after Achilles tendon repair. Well, guess what? Stick a needle in the gastroc and soleus, get it firing, restore the movement in the fascia. Guess what? You might have a muscle contracting and get your strength back. I've done it. I've treated people years after Achilles tendon repair and got their muscles firing, got their strength back. So this is what I did with my quadricep after I fell, and a week later, that leg was just giving way. Yes, I needle myself. Most needlers do. Hey, it works. So again, reviewing muscle inhibition. Muscle inhibition is a normal dysfunction of muscles. It's where muscle tissue loses the ability to contract. Once it loses the ability to a certain extent, it doesn't come back. Okay, all you nitpickers out there, just take this for what it is. Everybody's gonna find some little nuance to argue with. But it has been my experience for the last 12 years or so, because that's when I learned about muscle inhibition. So my practice completely changed, and the way I view the body and how I treat it completely changed. Muscle inhibition is the single biggest problem that brings people into my clinic. Plain and simple. Chronic pain, chronic musculoskeletal pain, trigger points, muscle inhibition. But along comes that with fascial restrictions, but I'm not going down that road. That'll be another lecture, another video. Okay, so let's see what happens. I'm going to turn up this side. So I just have a little handheld device that is a neuromuscular stimulator. It is not a TENS unit. A lot of people think TENS unit is for muscular stimulation. Okay, so I feel the tingling. It is really tingling. You might be able to see it to contract. Ooh, that's strong. Okay, I can't go up any further. That's feeling pretty strong. Can you see the needles twitching? Might be saying needles twitching. All right, I'm gonna do the other side. Oh yeah, I feel that. Oops. It would probably help if I put the other electrode on. It fell off. Oh yeah, that thing's buzzing. I feel all the way down. I feel it real strong. So let's do the other side. Maybe we'll get the muscle to contract. I might put it on pulsing so you can see it. Woo, mama. All right, let's put it on pulse and see if I can get it to pulse. There we go. Maybe. Ooh, a little stingy. Oh, it just contracted. Did you see that? I will uncontract it. There, can you see that? And contract. There. Oh, I just got the whole muscle to contract. See, y'all see that? I'll relax it. All right, I'll do it again. See, I got the whole muscle to contract. Okay, I am going to share one more thing about the quadriceps. There is part of the quadricep muscle. It's a tiny piece called the articularis genu. And I have a sharps container. I will take care of these appropriately. So just some quick anatomy lesson, okay? A very small part of the quadriceps called the articularis genu is part of the quadriceps that's very deep. It's attached to the femur and attaches to the capsule of the patella or the kneecap. When that muscle becomes inhibited, it becomes stuck down to the femur, and it also prevents some patellar motion, because obviously it's not the only muscle attached to the patella. But if you activate all the other components of the quadricep but forget articularis genu, you still have a huge component of the quadricep not firing. So let me teach you a little bit more about muscle inhibition. So we've talked about that it is a normal dysfunction of muscles. So let's talk about how muscles work. When you walk, every time you take a step forward, your leg swings forward where your butt muscle, your gluteus maximus, it has to slow your leg down so your leg doesn't fly off your body. That's called an eccentric contraction. An eccentric contraction takes more energy or is harder for a muscle to do, however you want to define it. So my experience working with people for the last 30 years is the muscles that do the most eccentric work in the body tend to be the ones that become inhibited and cause problems. Perfect example, gluteus maximus inhibition. If you're running or walking, if this guy's not doing its job to slow the leg down, everything down the leg is going to try to step in. That's where you get your hamstring strain, your Achilles tendonitis, your shin splints, your plantar fasciitis. Most of the time it starts from here. Yes, there are other things involved. Don't quote me that, oh, Sharon said it's only muscle inhibition. No, we're looking at the biomechanical cause of problems down the chain. Typically start with muscle inhibition in the butt. Another observation I have had over the years, rotator cuff tears. Most of the time they happen, they're insidious, or someone did one thing, or you didn't have a perfectly healthy rotator cuff just tear. Well, the supraspinatus and the infraspinatus are most often the muscles that tear. The supraspinatus, he's working to move the shoulder eccentrically, concentrically of course too, but definitely more eccentric work than the subscapularis. The infraspinatus, every time you throw or reach, the infraspinatus is slowing the arm down, an eccentric contraction. I guess over time, by the time you're 60, early 70s, these guys have worn out from muscle inhibition and they tear. So I hope that gives you some insight into what muscle inhibition is. Again, muscle inhibition is an involuntary loss of a muscle tissue's ability to contract. It is an electrical problem in the tissue. It is a literal disconnect between the muscle tissue and the central nervous system. It is a problem in the periphery, not the central nervous system. There is a sensor in the periphery or in the muscle tissue. Periphery means not in the central nervous system, your brain stem and brain. Periphery is outside of the central nervous system. So it is a problem in the periphery, in the muscle tissue itself, okay? It is a sensor in the muscle called the muscle spindle. It's gone slack. That spindle needs to be reset. And isometrics can do that, but they aren't always as effective as intramuscular electrical stim. So I hope that helps give you a little education on maybe why someone in chronic pain and no matter what they do doesn't get better, or someone's had surgery and they just still aren't recovering. I am pretty confident in saying it's muscle inhibition. Thanks.